You're listening to the Aesthetically Speaking podcast, presented by Nextech.
Welcome to the Nextech podcast. I'm Robin Ntoh, and I am your host today. And we have a very special guest, a plastic surgeon from the Washington, D.C. area, Dr. Stephen Davison. Dr. Davison, I am so pleased to have you on the show today. And one of the things that I love about your expertise and background is it's broad and it goes deep. So let's share with our listeners a little bit about your credentialing and a little bit more about your practice. Just give them a high-level overview.
So I've been in practice since 1999. The first 9 years was as a full academic attending at Georgetown University under Scott Spear. And then in 2008, Robin, who is a very close friend and associate of mine, helped transition my practice into private practice in Washington, D.C. I have a hybrid operation, which involves both reconstructive and cosmetic surgery, the full range of plastic surgery with the exception of really hand and craniofacial. My background is I'm a dentist, a dental specialist in head and neck reconstruction. I'm ENT and plastic surgery, triple boarded in ENT, facial plastics, and plastic surgery.
And because you didn't really think you'd done enough, because you're such an underachiever, you decided to get your MBA as well.
I did do my MBA in a John Hopkins in a physician cohort, which was really kind of an excellent opportunity to both learn the language of business and really broaden my interests into the business of medicine, which has always been a kind of caveat that I've enjoyed.
As it gives you an interesting perspective, so much for us to dig into. So I think it kind of ties back into the topic today, which is really around just trying to be a successful plastic surgeon. And there's so many components to it. And let's start with, you've got a lot going on in your practice. Your day is to see patients and to do surgery, but you're running a business. How do you manage all of this?
I think the first question you have to ask yourself is, do you want to manage that, right? And you need to do an internal inventory. You really need to ask yourself, do you have the skill sets? Do you have the interest? Is this what you want to do on a Sunday morning? In October 13th, do you want to be reviewing the K1s? Do you want to be looking over the profit and loss for the practice? Because you're probably talking to run a practice for non-remunerated time, 5 to 10 hours a week minimum. And that's if you're organized, if you're established, and you're not learning it every day.
That's a lot to manage. Now, you also have to think about the growth of your business while you're trying to manage the day-to-day and thinking about the what's next. When you're trying to manage the business, you've got the staffing part. Let's talk about just the staffing part for a second.
You said just, but to my mind, and particularly in plastic surgery, which is it's really a connection industry, right? I mean, we sort of think of it as a technical industry where we're doing things for people, but that's not really what it is. It's really a relationships industry. You've got to have very positive relationships within your own practice. Everybody inherently knows when there's one toxic individual on the team or there's breakdown in the environment, which begins to affect everything. So the management of people is really the most difficult thing and I think managing the practice. And it's more difficult now because of the competitiveness from all the other essentially sort of commercial medicine. So med spas, other specialties, other doctors delving into things which were historically plastic surgery's domain, dentists doing the Botox. So now you have competition, not just external market competition, but you've got competition for your staff. And there's no more acute environment than OR personnel right now, particularly a well-trained, experienced OR nurse. They have the ability to move around almost anywhere and be picked up with a bidding war at any opportunity. You not only have a problem of staffing and filling positions, but the fact that at any time your key individuals can be poached.
Well, it goes into my next question. So if you have staff turnover, or when you do have staff that either they move away and they were in a good relationship, you have a unique type of build around your staff. One of the things that was put in place in your practice was, you bring in these pre-med students, which is a unique way of thinking about how you foster them, grow them. I think you said you have 45 that are in medical school at this point since you've launched this program?
Yes, and 4 of them are either in plastic surgery training or are just finishing microvascular fellowship. So our program, where I take pre-med students and use them as the core of my MA staff, has really been a great way to both pay it forward and staff with really bright people. The only problem is they have a lifespan on average of 11 to 13 months. But the good news is that they can be trained in 3 to 4 weeks. And so it's a trade of turnover versus competence.
Generally, they've got a quick study. They learn quickly. They want to do this because it builds a skill set for them that eventually is going to be part of what they would do someday, whether it's plastic surgery or something else. But is there a playbook that you have put in place to transition? So you've got them from 11 to 13 months. Have you found the right way to really make that transition seamless at 11, 12, or month 13?
The group that do get into medical school, and most do, like this year, probably 3 out of 4 or 3 out of 5 will go into medical school out of the practice, is that they have to be trained essentially by the veteran. Now, what I have found that the individual who's leaving is not the individual to train you, because they have short-termers attitude. What is much better is if one stays in medical school in Washington, D.C., that's the ideal trainer. So we have overlap where we have, right now I have one of the MAs, she's a second year at GW. She does the training because her commitment is greater, her longevity is greater, her institutional knowledge is greater. That's how I solved that.
So the key here is you need to make sure at least one of them goes to medical school in your region.
In my region, yes. And that is not without a certain amount of commitment and lobbying.
I'm sure it is, but you've done a great job in that arena. But let's talk about systems. So we've talked about people. Those people, once you get the right people, and this is something else that you have to think about and you have to manage. Now you need the right processes and systems. What tips or tricks would you share that have been ideal in you managing different components of your business, whether it's staff or something else?
So one that comes to mind right away is to avoid operating room cancellations, right?
Okay.
You want to have a system in place in which your cancellation rate or your no-show rate, either for reconstructive surgery or for cosmetic surgery, is absolutely minimal. I mean, it really should be like under 2-3%. I mean, it should, in a successful practice, it should be really nothing. So one thing to do that is make sure your policies for collecting prepay, fee-for-service are well established. Make sure that, your staff adhere to those collection dates. And second, I think a pre-op appointment with a nurse for medical clearance and training 2 weeks before any surgery has really reduced that for us.
you've probably seen a lot of things that surgeons thought they were doing right, or things that may have been the right process, or they, for whatever reason, where do they think is right, but you've seen where it goes terribly wrong?
Yeah, I can categorize the fungi, pit problems that people get into. One, out of field surgery. And a classic example would be, a facial plastic surgeon retires from his practice, moves to a retirement type place, decides that he wants to pick up a little extra work at Sonobello and starts doing full body liposuction. And their experience is not that great in it, ends up being a perforation, but that's a problem. Next is ignoring medical clearance and or risk assessment models for things like PE and DVTs in the interest of getting somebody on the schedule too quickly. That I would say the second thing. The third thing that I see is the move towards domestic tourism. We think of medical tourism of like patients going to, say, El Salvador or going to Mexico and having surgery done. But that's what I call macro tourism. You also have micro tourism where you're going from New York to Miami to get your Brazilian butt lifts, but then you're returning to New York with no follow-up care. There's no connection. No one knows anybody. You're not being sent for, and you have problems in New York. So that's now what I call micro tourism. And then the third area is what I call turf tourism, where, your abdominoplasty is being done by the GYN when they do the C-section. That's turf tourism, right?
Oh my goodness.
Right. But these things happen, and I see these all the time, and those are the three buckets that the problems fall into: is inadequate post-operative care because of tourism. Second, not paying attention to the medical clearances based on economic factors, particularly scheduling. And third, out-of-field surgery.
You've got some tight processes. You're really focused in and honed in, and you're using your data. You've got the metrics, you're using your data, you're understanding your business. Where do practices, in your opinion, you've seen a lot of this, where do practices not listen to the data? Where do you think there's the biggest opportunity when you think about, you mentioned just the cancellation, that is key, but where else do you see practices miss?
A good example of that would be, we lose money on every patient, but we make it up on volume. There's certain aspects of my practice that, we already know that are a loss leader, like a reconstructive breast reduction is definitely a loss leader. Now,
right.
But on the flip side, if you do that work, then you endear yourself to that patient's mother, who then may come in for a facelift. It's becoming well known in the community. It's having a reputation for providing care that's appropriate, but you can't possibly make a living doing insurance breast reductions.
No, not at all.
The next thing would be product price control. Now, you don't want to get into a bidding war in terms of constantly lowering the price of your Botox and filler appointments or your injections, because every medical spa around you is running a constant special, right? To my mind, I think one of the important things in the med spa and filler market is that it's a relationship. It's sort of like your hairdresser. You want to enjoy that hour with that person and trust that person, not what the cost per unit is.
Yeah.
Most of the time. Now, you still take advantage of the Mother's Day special. That's not the same, but you're not changing just on the price point. Another thing that I think is a very important thing, and I've made this mistake multiple times, is that I buy a piece of equipment that delivers some non-surgical modality that's supposed to enhance the practice and bring in new revenue, and then I'm selling it. and that annoys the living daylights out of me. And then the minute it's paid for, I'm disinterested and we never use it again. But what I found over time is that none of them work unless that's your core market. If you're not doing a lot of laser facial resurfacing, you don't need to buy a laser. It's just not a good economic model because now you're selling something that's not really your core.
So this bridges nicely into my next question then. So how do you determine when or what new service line you might bring in?
I think you first have to start with a motivated, passionate individual who's going to do it other than you. If you don't, if you don't have that, don't do it. Right? If you don't have somebody that's really excited about the idea of doing PRP microneedling, then don't add it. Right?
Even if it's got a great demand in the market, for example, like GLPs.
Let's take GLPs. Now, we had an opportunity to get into the GLP market. We could have done it quite easily, had a pretty good compounding pharmacy. But the problem with it is that, do you have the setup to monitor the patient? Do you have the nurse practitioner or the PA that wants to look after them and nurse them through what is, an uncomfortable beginning to the process? And next, do you really want to be the practice that's now named in a class action suit when it doesn't go well?
Not really.
I did not want to. And so I made a conscious decision because that's not my core business, right? And I didn't want to be distracted. And more to the point, no one in the practice wanted to do it. So it had been just another thing that I was selling that I didn't want to sell.
And you bring up a good point. You've got to have the team or the staff that are going to be on board with us and they're going to be supportive of it. And your part of your core business is you have the surgery as a major core part of it. You build out a beautiful new OR and you actually, you have contracts where you actually do insurance procedures in there as well, which is an important part of a plastic surgery practice. When you think about your business and the management of it, what makes you stay up at night or lose sleep at night?
Simple cash flow. Anything you build is going to cost you 2 to 3 times. Anything that you build is going to have a delay, which is outside your control. The individual in Washington, D.C. that licenses medical facilities went on sabbatical for 7 months, so we didn't get a license for 7 months, right? Then there's no one else can do it. They'll be back, right? Well, you can imagine the carrying costs of 7 months for a brand new surgery center. That's a cash flow problem because you're anticipating the income from the surgery center to pay its own note. But now you're paying for it with clinical income. So that's cash flow is a problem. Next thing is, again, the delays of things like provider contracts. We started doing surgery September of 2024, and we only just got the Blues contracts effective May 1st. So that's right. That gives you a timeline and a delay that it's got nothing to do with you. It doesn't matter how competent you are, how you fill the paperwork out, is that the carrying cost and cash flow, you better have a deep pocket.
Especially when you're, your core business is surgery.
Yes.
It's a core business. To that end, you brought on a second surgeon.
Yes.
From a management perspective, what would you tell anybody about that if that's part of where your journey takes you, if you're a surgeon that is going to first, why a second surgeon, any way that you would want to position what to think about when you're doing that.
I think you have to very carefully think about why you're bringing on another doctor. And is it a financial dilution of the expenses? Because I think you're going to rapidly find that that's not real. That doesn't work. The expenses go up with the added manpower. They need their own patient care coordinator. Now there's more laundry. You need a bigger space. I think that idea of the dilution of the expenses, I have not seen that, right? Next, social. I was 24/7, 367 on call. In addition, my wife was the injector in the practice, so for us to go away for a week was a six-figure problem because it was all the injectables stopped, the OR facility stopped, the surgery stopped, the consults stopped. So a family vacation started at six figures.
Before you even left the door, before you even got on the plane.
Yeah, before we even packed a bag, it was a multi-six-figure problem. But now I have someone to help cover the cost from a social viewpoint to keep the lights on when I'm gone. And then life circumstances change. Sometimes you need a partner to cover you. And I had a bad motor vehicle accident, and my partner was there to do the surgery in the practice for a month, right? I would have gone out of business. So that's a social benefit. Trust in somebody else that you can be away. I mean, I don't look at my phone when I'm here now because I have a partner and a very trustworthy, excellent, competent surgeon. So they will take care of things. She will take care of things when I'm gone, right?
Peace of mind.
Right? Then peace of mind. And then the third angle on it is exit planning, right? You've either got two choices. You either sell something out to another doctor or doctors, you sell it out to private equity, or you lock the door. Now that blue sky doesn't have any value and the new generations think that the practice is built more on, and they may not be wrong, more on social media and exposure than it is on historical, clientele. And that's not a criticism. It's just that's a way that things have changed. You need to have an exit plan, right? And that's why a partner is not a bad problem. I think the hard thing in a partner, having had 9 partners and no partner and now one partner, is I think the most difficult partner is the first one. I think the third partner will be easier and the fourth one will be a cinch because the processes for acquisition, for shared expenses, for remuneration, for retirement, they will all be in place for the next one.
Right.
But the most difficult is the first. And I think there's a lot of naivety on both sides of the equation, both on the person taking on the partners and those that are joining.
I think that you said something that was important to tease out. A lot of practices that go into, they bring on a partner, fail. And we see a lot of that. We see practices that are doing data splits all the time. They're not really pushing through and getting beyond that point of, okay, there's that honeymoon phase ends very quickly and the first few years are really rocky. But once you can get beyond that, and then there's a true partnership that's leveling up, and then you bring on the second one, that is when you hope to see where the business really benefits. But I think that people go in and they're short-sighted and think that it's going to happen much sooner.
Yeah, so I think the fastest I've ever seen an incredibly busy associate become profitable is at Georgetown. Peripheral nerve surgeon, no competition, first generation immigrant, paranoid economically. They were financially viable in 7 months. I would say the average is 24 months. So that area under the curve is anywhere from 7 months to 24 months. And then the period to pay it back, where you're now adding economic value to the practice, if your salary stayed the same, is another 2 years. So I think that first 4 years, it's not until you get to 4 years are you really stable with that partner. And that's the hard part. And then when that person makes partner and is now in a power, economic, referral, sharing type relationship, maybe not complete equity with a senior person, I think there's six years minimum, maybe 10 before you're ready for the next person, because the next person that joins always cannibalizes something. And the hard part is they're not going to cannibalize from the most senior person. They're going to cannibalize from the person who came in last, and that's going to make them paranoid.
So from a business move, let's think future. 5 years. Let's just do 1 year. Crystal ball. We know technology is evolving so quickly. We would be remiss to not talk about, where does AI fit in plastic surgery?
I think AI summary to collate everything. And when I say collate everything, I'm talking about all the information that's available, for instance, in medical records and a Nextech chart. I want to know what quote they picked, correlate it with the TouchMD pictures, and make sure that that's also what was on the consent, so that you're not having those uncomfortable things. Were we supposed to have ordered Galaflex, but we didn't order the Galaflex? Or maybe you got the Endotine and not the Endobrowpexy, and these are sort of like clear examples in my practice. So a summary of the plan will be helpful. And secondly, what I would really like to see AI doing is real-time communication out to the patient of, this is what we talked about. This is what my assessment was. This separates me from everybody else you're going to see by next week. And I want that customized letter to go to you real time within like 24 hours, right? Or
It's
even
a great way to think about it, though.
Right. Because I do letters now to patients summarizing, but I get so far behind on them. But if AI can do those for me by the end of the day, now it fits my practice with technology.
I think another area in your business is you do insurance procedures. Your partner does a lot.
Yes.
I think there's opportunity there from an operational perspective.
Well, right now, the practice burden to generate a reconstructive dollar is like completely out of context. You got to have somebody doing pre-certifications. You got to have somebody doing the scheduling. You got to do letter of medical necessity. You got to make sure that the charges weren't denied. The codes were kicked out. The pre-certs. If I can sit in a room and literally on a piece of white paper write down what my codes are and what the diagnosis codes are, and have a letter of medical necessity generated for that breast reduction, and have the pre-cert done by the end of the next day, because it's all an automated AI process. I've eliminated, a $70,000 salary for a pre-cert person. And that's where this AI is going to start seeing a return on investment in a reconstructive practice.
From a business perspective, you also think about that 10 hours that you're spending a week managing your business. It's managing your business plus being the doctor.
Yes. There's one other thing I brought up in terms of reconstructive practices. I brought up today that we're going to get into a remuneration death spiral with AI. You watch what's going to happen here. It's going to be a remuneration death spiral. So the way that Medicare works, Medicare is it's a closed financial system. It's X number of dollars tagged to the GDP divided by the number of RVUs which is sent in. So what's going to happen is AI is going to get smart, and AI is going to automatically fill out all the boxes. So every single consultation at every single doctor's office is now a level 5.
Yep.
Because we're going to tick all the boxes and all the criteria. Then what that's going to do is the first 6 months or 7 months or 9 months will be fine until the next Medicare balanced budget. And then what will happen is the RVUs will go down. And then that medical visit, instead of being worth $159, is only going to be worth $119 because everybody submitted level 5s.
Sure.
And Medicare is going to say, well, we need to audit everybody because how can they all be level 5s? But then the AI is going to have filled in, and it's going to create this death spiral of remuneration for reconstructive visits.
Yeah, so I think that this is where there's this balance of hype, myth, fear. Where do we see this? And you're right. I think that software can do the wrong thing, which would be the wrong approach that's going to have a bad outcome if we're not careful.
I think the other important thing is that AI scribing and AI data mining in the charts has the potential to add vastly too much information into the charts. And two types of information. One, repeat information that doesn't add anything,
right?
Which it already does in like a perfect example would be Epic. It's impossible to find out in an Epic note what happened, right? I mean, it's just words. The next problem will be if you use the technology to capture everything in the consultation, there's going to be some things in there that people aren't going to want in the notes.
Absolutely.
You're right. Perfect example would be a labiaplasty consult. That's not going to be what the patient wants in there, right?
You're right.
Right. All the euphemisms that you use to get around things or to be polite are not going to translate that well.
No, you're right. It's figuring out what the right information is. So to close this out, if you could give some great advice to your younger self when you first started, what would you say to yourself?
When you're starting out, is you've got to take a personal inventory of what your skills and what your interests are, and not do what a mentor did or not go where you're expected to go, but to do the things that really suit you. If you have no tolerance for numbers and for money, and that stresses you, be an employee, right? Right? If you're not a follower and you consider yourself kind of like a pioneer, kind of like, someone that was set out in a red wagon on the Oregon Trail, you may be one of those doctors that still does well in private practice in a solo practice, right?
Right.
If you never played a team sport, don't think you're going to do well in a 9-man group, right?
Very good point.
But I think you should take a look at yourself before you jump off any cliff.
In other words, don't just follow a mentor, follow you and be true to you.
Yes. I think you've got to know you to follow you first.
Sure.
So take a weekend, take a week, take a month, and maybe take the last 2 years of your residency to figure out who you like, where you like, what you're good at, what you're not good at, what stresses you, what doesn't stress you, what fills you with energy, do you want to be a mentor? Do you want to have employees? Or do you just want to go in and get out because, you've got kids to get on the bus, right?
Right. Well, this has been excellent. Thank you so much for joining us today. And I am excited about where this takes us next.
And thanks to you for giving me such a wonderful start. You did about the best job anybody could have from transitioning from an academic to a private practice, and it's been nothing but positive and growth since 2008 when you made it happen for me.
Love it. Thank you.
Thanks for listening to Aesthetically Speaking, the podcast where beauty meets business, presented by Nextech. Follow and subscribe on Apple, Spotify, YouTube, or wherever you like to listen to podcasts. Links to the resources mentioned on this podcast are available in your show notes. For more information about Nextech, visit nextech.com, or to learn more about TouchMD, go to touchmd.com.